Good evening, all. I'm Dr. Durgesh, Senior Consultant, Critical Care Medicine at Yashoda Hospital. So today evening we'll be discussing in our master class burn case. Burn case is very quite common in our exams also. There is a long case of burn. So it involves a lot of aspects like fluid resuscitation, early identification, various formulas incorporated in. Later on, we have to battle with the infection part. So to take us through, we have got two senior examiners. One is Dr. Gunadhar Paddi. So good evening and welcome you, sir. He is
Hi.
a he is a child intensivist at HN Reliance Hospital, Mumbai. Another examiner, Dr. Anand V. Joshi, he is about to join shortly. So he holds a dual degree, Indian as well as Australian degree. So he is senior intensivist. He will be joining shortly. And to take us through our case, we have our critical care resident from KIMS Hospital, Secunderabad, Dr. Ravi and Dr. Amrita. I think Dr. Ravi and Dr. Amrita, you can proceed with the case.
Okay.
You start your screen sharing.
Yes.
Good evening, sir. Good evening, everyone. Today,
Yeah.
my case is about the burns case. Here, the patient is a 35-year-old male electrician by profession with no medical comorbidities, no prior history of diabetes, hypertension, coronary artery disease, or CKD. He presented with extensive burn injuries following an occupational accident. He complained of severe pain, predominantly over the chest and both upper limbs, extensive burn injuries over the face and anterior chest and both upper limbs. The injury occurred approximately 1 hour prior to hospital admission. While working as an electrician, the patient accidentally came into contact with a high voltage electric line. Immediately after contact, his clothing caught fire, resulting in additional flame burns.
So just a minute. So what are the sequence of events? So he was working with the electrical wire and then
He was
he came in
working.
contact.
Yes, sir. He came in a contact with a high voltage electric line, sir. After
Okay.
that, his clothes got flame, sir.
Okay. So this is outside the residential campus. You meant to say?
Yes, sir. Yes, sir. Outdoor exposure.
Outdoor. Okay. How it is important?
Right.
Like
If it is
why this
indoor,
kind of injuries?
uh,
Why this kind of injuries are important?
carbon monoxide and cyanide poisoning are generally in the indoors, closed space injuries. I mean, they tend to be more. And whereas outdoor, the incidence of them is very less because um, uh, what is it? Distribute so that inhaled gas won't be so concentrated. So that makes
Okay.
us.
And what is the importance of the high voltage? Said high voltage. Like, what is the exact approximate the voltage?
More
Like,
than
any
10,000.
idea?
More than this is more than 10,000 volts, sir.
So, more than 1,000, more than 10,000. You mean to say?
10,000.
So, what type of current this is? Like, what type of
It's a
current? Like, it's a
direct currents.
okay, direct
Currents.
current. Okay. So, how does the burn injury differ between the two types of this current flow actually, alternating versus the direct, which is more dangerous? And
The impact of burn injury with alternate current is very low, sir. And with the direct current, it will be high impact of burn injuries, sir.
so how is the mechanism like? What does actually the alternating current does to the body? So you are presenting a case of electrical burn, right? So though it is like it is a burn injury, particularly you are like what I just seeing here, it is a complex burn injury case, electrical burn injury case, which is actually sometimes many times these burns are very important because see in the electrical burn, particularly the extent and the depth of the burn injury is sometimes is not reliable from looking from the outside. So here the history, the mode of injury, the type of exposure, and how like what exactly the sequence of events are very important compared to the other ones. And you told that there is of course this is outdoor injury, so chances of the carbon monoxide and cyanide toxicity is less. But here the more important thing is the type of current exposure. So like if it's a alternative current, particularly they can cause uh, tetanic spasm to the muscles. Okay. And that because of the tetanic spasm, so the exposure time of the burn injury with that particular electricity is more compared to the your direct current. The direct current can like it should like suppose the patient got exposed to the direct current, it maybe got thrown away immediately. Okay, so the exposure time is less. But here, since you have mentioned it is a high voltage, of course the high voltage lines are causing more damage compared to your low voltage lines. So that is the only thing. But if you compare the voltage between the same two alternating versus the direct, your alternating currents causes more injury, underlying muscle damage, the necrosis, and your tissue damage more compared to your direct current because they produce a series of tetanic spasm. Okay, because whenever the current passes through the body, it produces the series of tetanic spasm. So those things are ideally it is very important. Exactly you have to mention where this injury and how the injury has happened. Actually, this is how your treatment line and your subsequent prognostication and the outcome of the patient actually depends. Okay. So, okay. So, and this is also with some additional flame burns. Okay. So
Yes,
basically
yes.
this is a electrical burns with a additional flame burns, right?
Yes, sir.
Okay. So what is the importance of these flame burns along with the electrical burns? So basically, both the thermal injury, the patient will have thermal injury along with the electrical injury. So two types of injuries you can expect here. So
Yes,
the
sir.
effect of the thermal injury and the electrical injury. So what are the effects of the electrical injury particularly?
Electrical injury, there will be a muscle injury will be there, sir, and it can
Right.
lead to rhabdomyolysis and myoglobin. There will be increase in the myoglobin, and it can lead to the pigment nephropathy, and it lead to AKI in electrical injury. Whereas in the thermal injuries, there can be there will be increase in the capillary permeability and extravasation of the fluid, and it can lead to the edema of the tissues. And
Right. Correct.
yes, sir.
Correct.
Sorry to brought in late.
Oh,
Today
hi.
Anand here.
Dr. Anand has joined.
Hi, Dr. Anand. Hi.
Hi.
So just we are started, sir. Now just like.
Yeah, go ahead.
Yeah. So we have just started. We have just I think we have finished 3 slides. So
Right.
they have
It's a-
just discussed. So can you just go to the next slide?
Yes, sir. There was no history of fall from height, no loss of consciousness, no seizures, no pre-hospital cardiac arrest.
Why?
No
Why?
history.
1 minute. 1 minute. Just wait. So this electrical injury. Why all these histories are important? Loss of consciousness, seizures. Why you have taken that? Like why you have mentioned like what is the importance of the negative history here?
Sir, normally if the high voltage electric lines are in the height, there can be a fall of the patient from the height, and there can be a traumatic head injury, and there can be a loss of consciousness.
Cervical spine injury
Yeah.
can also be suspected, sir, in such cases.
Okay. Okay. And what about this second point? You have mentioned about the level, no loss of consciousness. Why the person is unconscious? What does it indicate particularly in case of electrical injury? And about seizure also?
Any brain Any brain involvement is there? Following a fall from the height, there can be any brain involvement, and we have to evaluate the neurological CT scan and all. We have to do, sir, evaluation.
No, that's okay. But how does the electrical injuries basically cause loss of consciousness and seizure? Is there any mechanism, I mean to say, where such type of injuries can produce seizure and loss of consciousness?
See, basically what you are looking at is the huge electric current, right? Which is passing through your body, correct? So anything
Yes,
that is having an automatic electric current circuit are going to get disturbed, right?
yes, sir.
Okay. So which are the organs which throw electricity in the whole body? Automatic electricity.
Brain and
Most important, brain and
Okay, I will give you a hint.
Neurons.
You check for that particular electrical current every other day, and once in a while for the other organ. One you already told, brain. So you put the electrodes on it, and then you look for the electric current, right? What is the other one, which is the most common now you do?
heart, sir.
Heart. So there are only two organs in the brain that has an electrical circuit which works on the electrical, right? And both of them you use as a therapeutic a high voltage thing to stop those electric current, right? One you do a DC cardioversion, and in the brain you do electroconvulsive therapy, right?
Yes,
Now imagine these are the controlled way you are using electricity. This is an uncontrolled way the electricity has entered into your body.
Yes, sir.
So obviously
So what
you
will
have to
happen?
look. Yeah. So this if you remember this, then you will obviously your focus will go and all your negative history will come there. Correct?
Yes, sir.
Loss of consciousness, seizures, cardiac arrest. So you are involved both brain and heart is there or not.
So basically, these are all sequential events. All right.
Yes, sir.
So yeah. So that is very important actually. So patient who become presented to you, there may be like go into one is cardiac arrest because of the arrhythmias, because of the heart block. Sometimes it may be early and delay. And second is because of the unconsciousness and seizures. Because of the cardiac, your low blood flows, because of the conduction system, the patient can grow into bradyarrhythmias, and that can also cause low cardiac outputs. And sometimes per se they can cause direct injury or neurotoxic. Does it like the electrical injury? What are the effect on the different organs, particularly the nerves, the muscles, the brain? How does that affect actually?
Sir, I didn't get your question, sir.
So how does the sir is asking what are the effects of electrical injuries, or rather electrical injuries of affecting the different organs? So you spoke about the heart, you spoke about the brain. What are the other injuries it can cause and what they can present as?
Sir, in heart, they can cause arrhythmias like ventricular fibrillation is the most common, and in the brain, it can lead to seizures, and there can be a loss of consciousness, and with electrical injury, there can be a increase in muscle injury, and it leading to the myoglobinuria and precipitating in tubules and leading to AKI. And in
Right. So if you little go into the deeper the pathophysiology to the cellular level, basically. So if you see the current passes through a particular point, there you have a nerve, you have a muscle, you have a skin, you have a bone. So what are the sequence of your harmful effect which is being observed in these particular organs? So which is more prone to the electrical trauma, the electrical burn? Which tissues like nerves? You have a nerve, you have a muscle, you have a skin, you have a bone. So how soft tissues? So in which sequence of events this cellular level of effect is being seen?
Nerves will be involved first, sir. After that, soft tissue will be involved, and in the last, bones will be involved, sir.
Generally,
Okay, why so? Why so?
Electricity generally prefers least resistant pathways, sir, wherein the nerves come the first. So that's the reason why nerves are affected initially. I mean,
Right.
they are affected.
So basically, like you're right then. So if you like go to the basic rules of this law of physics, actually, little bit physics is involved here, like the Coulomb's law and the Joule's law. So the heat which is generated is basically directly proportional to your current, intensity of the current. So the more is the intensity of the current, more is the thermal burns. And second thing is regarding your what we call the resistance. So the tissues which are having the lowest resistance, they are more affected by the current. Okay, so like the nerves has the lowest resistance, as you already mentioned, and the bones has the highest resistance to the current. So that is the reason. So bones are like whenever the electricity passes through the bones, actually they generate more heat compared to their level of involvement, and because of that, the surrounding muscles they get charred actually. Okay, so that is the reason the myonecrosis in this kind of injuries are very, very profound. Myonecrosis is the most intense and the most dangerous form of the your burn injury in case of electrical injury. That is the reason we are more worried. So in the skin, if you see, the skin may not be affected to that extent, but the muscles in the underlying fascia and the deep tissues, they are involved to a deeper extent. That is the reason whatever you looks from outside, actually it is not true, because they have an extensive deep tissue involvement, and that actually leads to a lot of your organ dysfunction, like rhabdomyolysis, your coagulation necrosis, reperfusion injuries, your arrhythmia. All those things are because of the deep tissue involvement. That is the basic take-home message actually in the electrical injury. So yeah, I'm right, Dr. Anand. So you want to have some comments?
Dr. Anand has
Okay.
muted.
Okay, no problem. So this is the one of the most important take-home message. So that is the reason. So whatever you like estimate the burn wound depth and the extent of the burn wound injury from the outside, actually that doesn't really correlate with the clinical syndromes and the clinical spectrum of such patients. Okay. Yes. So yeah, we can move to the next slide.
No history of asthma or COPD, and no any known drug allergies. Is a non-smoker, no alcohol consumption, and no tobacco chewing, no previous major surgeries. Last tetanus toxoid booster took 10 years ago.
Fantastic. At least this history you have taken the tetanus toxoid. Huh? It's a good thing.
Yeah,
So how
that
does
is
it?
that is very good. Yeah,
Yeah,
I agree on that.
Yes, so how does it like? Why it is so important in particularly this kind of burn injury?
Sir?
Is it important or not? So you have given a history, tetanus toxoid administered
Yes,
more
sir.
than. So how does it like? What do you plan? Suppose, for example, this patient who has taken a toxoid booster more than 10 years ago. So what is your like? What do you want to
If
plan for?
recent history is there, no need of administration of tetanus toxoid, sir. Otherwise, we need to immediately administer because they are highly prone for tetanus.
Yeah.
So immediately after receiving the patient, when we get to know regarding the history of tetanus toxoid vaccine, if it is more than 5 years, we have to immediately administer the vaccine, sir. Because these patients, though we take utmost care, tetanus is the one wherein if we miss it, it is inevitable, and that becomes the cause of death in these cases.
Yes, correct. Okay.
So at presentation, sir.
Go ahead with next slide.
Sir, at presentation is vitals of BP 95/60 and heart rate is 110 beats per minute and respiratory rate is 26 breaths per minute and oxygen saturation is 95% on room air Temperature is 36 degrees centigrade. GCS is 15 by 15. Pain score was 9 by 10. Severe and aggravated by movement, and peripheral pulses were weak.
Okay. So, like this patient is in right now in the ER. He came to
Yes.
in the ER or in. So it's
Yes.
like you are the person who is assessing this patient in the ER, right?
Yes,
Yes,
sir.
sir.
Okay. Okay.
Anything else you would have asked for? Again, ECG.
We have taken it later, sir. I mean, these were vitals on admission. So
Oh, okay,
ECG
fair enough.
Oh, okay.
Okay. Just a question: why he was so painful while moving?
Sir,
Why do you think he was there was having excess of pain during movement?
sir, due to these burn injuries, some are superficial burns are also there, sir. Superficial areas also there. So, when there is a superficial burnt area, there will be a pain, severe pain will be there, sir. So, because of that, during movement also, he is having pain, sir.
Any other reason, especially related to movement? So basically, he will be having a lot of tissue damage
Yes, sir.
there.
Yes. Yes, sir. In electrical current wounds
Where
also
will be
there.
the tissue damage more?
In electrical current, from the entry point to exit point, there can be a extensive tissue damage can be there, sir.
Correct. But any particular area, because it will be say having from his right finger, and the current went out through his left toe. So do you think that the tissue damage will be equal in all of them, or there will be particular places where there will be more tissue damage as compared to tissue damage?
It won't be equal, sir. It depends on
Veins, nerves, depends on.
it depends on extent of the injury. It will be there, sir.
generally,
Okay. So what is the importance of what is the importance of current crossing the joints? What happens? Is there any continuity in the joints? It can flow, or the current experiences a resistance while passing through? And what when there is an increase in resistance of a current?
when the current passes
So
through the
basically,
joint,
when the current passes through through the joint, what happens?
There will be increased resistance.
There is no continuity, right? Like,
Yes, sir. Surrounding tissues
correct.
will be
So
damaged.
there will be increased.
necrosis.
Correct. Yes, correct. So when you are having electric current, so there will be a more amount of localized heat because of the resistance produced, and there will be increased tissue damage, and hence when you try to move at every joint, there will be excruciating pain.
Yes.
Yes, sir.
So this is
So
the
that is the
exactly
reason that fellow was shouting.
Correct. So this is again the same thing. Like it's actually the voltage is one thing which actually impact your nature of the injury, and second is the movement, the pathway of the current. Even if with a lesser voltage, the person can have more symptoms and have more tissue damage if the path of current is like this. Okay, so that is the reason it doesn't purely depends on the your voltage of the current. So both the factors are important in electrical injury.
Yes, sir. Okay, sir.
So whenever there is a conduction, so you have a conduction, you have a blood vessels, you have nerves, and you have a muscle tissue. So and the other muscle tissue which are generating electric circuit. So the most sensitive, as sir has asked before, most sensitive are those who have their intrinsic electrical activity like heart and brain. The next one to affected will be the one with active contraction, active and passive contraction, that is the muscle, and they go in an extreme path to the left. and that when it all affects your diaphragm, it affects your respiratory muscles, then choking episode, and that's how the person can die. So the muscle injury becomes a very important, and then the third will become the more damage happening at the joints, and then the rest of things are the ancillary problems which you will see as a part of the follow-up that we can come later. So that was the answer which sir was looking for when he asked you in the last slide.
Absolutely.
Am I sir? Am I right,
Yes,
sir?
yes, absolutely. I think
Yeah,
this is the basic pathophysiology. Yes.
All right. Got it?
Yes, yes, sir. Please.
Yeah. Okay. Let's go ahead.
Airway. On arrival, airway assessment revealed that airways were patent and patient has hoarseness of voice. Examination showed singed nasal hairs and facial burns. Cervical spine protection was maintained during the evaluation.
I think
Any
it's a very
particular reason you look for these things?
Sir, for hoarseness of voice and singed nasal hairs and facial burns, that can lead to the inhalational fumes that can lead to
Was the
inhalational
history suggestive? Was there any history of fire or confined fire?
Yes, sir. It is a mixed electrical and flame thermal injury, sir.
Okay.
Okay. Bilateral air entry was present and no V's and crepitations were noted. Capillary refill was delayed, though peripheral pulse were palpable. IV line 18 gauge cannula was secured in the left lower limb, and right central venous catheter was planned.
Okay. What are the challenges you may face while initiating the resuscitation of these patients? And what are the solutions?
Difficulty in finding IV access, sir, for a burns patient.
What are your options?
First thing is for searching for the IV cannula itself. And if we don't find IV cannula, we have to take the help of intraosseous guns and take access for it. Then that is for the IV access. And second one in the burns patient is
No. There is one more thing in IV access. Sorry, there is one more thing in IV access, which is your bread and butter. What prevents you from putting a central line under ultrasound guidance? Is there any contraindication?
no, sir. Only if
you will eventually put it, right?
Yes, sir. Yes, sir.
Yes, sir, we'll put.
Yeah.
No,
So what prevents you from putting it in here?
Yeah,
Unless it is a contaminated wound and all those.
Yes.
Just 1 minute. So you have only taken one peripheral, okay, and what about the other limb, the right limb?
Right limb. I mean, this was on arrival to ER, sir. I mean, ER has ER people called us by just securing an engage, and by the time we went, okay, we decided to put central line in the right femoral limb.
Okay. So one more thing, you told here that the capillary refill was delayed, but can you just go back to the first slide? Somebody has written the capillary refill peripheral pulses are weak. Okay, fine. So I thought it was there. Okay, sure.
Yep, go ahead.
Neurologically, the patient was fully conscious with a GCS of 15/15. Pupils were equal and reacted to light, and there was no focal neurological deficits. No associated traumatic injuries were identified.
Okay. What are the prognostic features you will look for in these kind of patients, and how will you prognosticate them? Neurological prognostic, basically. Suppose this patient has come in coma, heart is going okay, pupils are fixed and dilated. Will you poor prognosticate, or you will give a time before you poor prognosticator. This is as against the difference of the out of hospital cardiac arrest.
The prognostication in burns patient we'll do with the box scores.
That is for the burns patient.
Yes, sir.
This is a brain damage.
Here we would take some time to prognosticate the case, sir, so that we would evaluate the patient first. I mean, either as you said, if the patient is unconscious, we would like to do the CT brain.
So how much time you need actually before, like how much time you tell? Suppose now the sir asked you that patient is dilated pupils, is neurologically unconscious. So yeah, you decided for a CT, but the family is asking that is he going to like awake, or what about the clinical, like what do you think the clinically? So how do so 24 hours, 48 hours, 72 hours, what will your timelines?
72 hours, sir. I mean, why I say 72 hours is that at 48 to 72 hours is ideal time to prognosticate if there is any hypoxic ischemic encephalopathy in such cases, because for MRI to evolve or so, it takes 72 hours for our findings in MRI. Then in Burns case, first I would say, I would go with ABC, and then I'll send the patient for the CT or MRI, whichever is CT brain, sir, initially, and then see are there any evidence of traumatic brain injury for such because of any fall from the height or due to height electric current passage. Is there any damage that has occurred, either the form of bleed or some SDH, which has led to the mass midline shift in the brain that has to be evaluated, sir? So that I would do after ABC. And then if the patient comes unresponsive itself, I would ask in the history since when the patient has become unconscious, and is there any history of, whether they have observed any seizures or myoclonic jerks during the transit time, so that that would help us in prognosticating, or even in the treatment itself. It may help us to be driven in that way, sir.
Correct. So you have covered it very well. So basically, you can say it in this way also. You would like to rule out primary reason and the secondary causes of his loss of consciousness. Primary reason being the electric current shock itself, and the secondary cause, secondary trauma, secondary bleed because of that, for which after doing ABC, you would confirm with the imaging, and if required, you will do an EEG in case if you are looking for the neurological or non-convulsive status epilepticus. So that would be the answer. Right, sir?
Yes,
Yeah.
absolutely.
Yeah, correct. So that would help you to the neurological prognostication. Usually, even though fixed dilated pupils are there initially,
that's
primary,
what I want
is,
to.
Yeah, so it may not be the same prognostication as what you will see in out of hospital cardiac arrest. These people do recover pretty quickly, and if it is just a primary reason for it.
Yeah, so that's what actually the again another take-home point. Like don't have to so hurry in just giving a prognostication model, because these patients you have to wait. Okay, sometimes there may be a chances of delayed response, because initially for 48 to 72 hours, sometimes there may be a lot of inflammation, reperfusion, direct nerve injury. All these things may be going on, and sometimes these patients may do sometimes better, even if they are having a fixed BP, or sometimes like you feel that the patient is in coma. This is just like an occult snake bite, where you have to give time, and sometimes wait for the recovery to happen. Okay, that is what is the main thing, because whatever you see from outside doesn't really coincide in case of electrical injury. That is the main crux.
Yes. Okay.
Go ahead.
The burn injury was classified as a mixed thermal and electrical in nature. The facial burns was superficial, partial thickness, The anterior chest and both upper limbs were deep partial to full thickness burns. Using the rule of 9 in adults, the facial involvement is accounted for approximately 4.5%. The anterior chest for 9.
So yeah. So you have just written many of the theoretical part here, but let's cut the thing short. So basically, one is the assessment of the electrical burn area. Does the rule of 9 is like it is exactly hold true for the electrical injuries, like the
No,
other
sir.
traditional or conventional burn injury, or like that is something different? This is one thing, and second thing is like what you have written here is like the important thing is entry wound and the exit wound actually. So how does
Yep.
these two things are important in case of the electrical injury?
Sir, in thermal burn injuries, we will calculate according to the rule of 9, sir. But whenever there is an involvement of the electrical component, we will add a 20% to the thermal burn percentage, sir.
Right.
If example, we got if thermal burns were 31%, we will add a 21%, 20% to the 31, and the total we will assume it as a 50% burn, sir.
Right. Correct. And what? How about the wound type of the wound matters, like the entry wound and the exit wound? How does it important for you actually?
If the distance between the entry wound and the exit wound is more, then there will be an extensive muscle damage will be there, sir.
So which wound is usually smaller in size? Which wound looks like little extensive, more extensive, and which wound is smaller in size, and which wound is like the extensive necrosis of the tissues? In which wound? So which wound is more important? Like the examining of the which wound, either entry or exit, which wound is more important? Like, to give you a rough idea about the type of damage the person has. Entry or exit?
Exit wound, sir. Exit wound will have the more damage, sir.
Right. So that is the reason, yes. So that is the reason the examination of the exit wound is very, very vital. If the person has an electrical injury, the exit wound actually gives a better idea and clear idea of the type of the injury. And most of the times, looking at the exit wound, you can realize that this patient is likely to go into the rhabdomyolysis or AKI or hyperinflammatory syndrome. So whatever or extensive tissue damage because of the burn, electrical burn, all these things are better assessed with the exit wound. So examine the exit wound thoroughly, see their length, see their depth, their extent, their nature, their character, the damage that has occurred around this burn area. There may be multiple exit wounds, so examine them individually. It will give you a better idea actually.
So here the total burn surface area is approximately 31.5%. On local examination, the entry wound was identified as a left palm and the suspected exit wound over the left forearm. It is consistent with the electrical current passes through the upper limb.
Okay, so he didn't had a proper going through the legs or anything. So he was
No, sir. No.
yeah, lucky guy.
So I
Initial,
have just one question is here in the chat box. Can we take right now one question here? Is there any role of venesection in this patient? So
venesection, I remember I'm doing it during my undergraduate days. After that, it has almost after the advent of ultrasound, almost venesection is abandoned. Nobody does it because those days the ultrasound was not so extensively used, so access to the veins was always difficult. So we used to cut down the vein. I don't think
right.
nowadays anybody uses any venesection.
Correct. So what I can only point out that regarding the intraosseous, sometimes it may be difficulty in finding the IV lines in a patient who has extensively burn injury. Those cases nowadays we are not practicing, but I have seen few cases with the intraosseous line being taken for the resuscitation. So what is your view, Dr. Anand?
Yeah. No, that is that. Now, in fact, intraosseous lines was little bit hesitated because the amount of pressure and the power we required when we used to do manually was too high. But now with the advent of gun, it is all one shot and it's in.
Yeah, very
So
easy.
I think
It's now
if,
become very easy.
yeah, if you have a gun, then that
Yes,
has
yes.
really made the life very easy. Otherwise, just drilling into the tibia was like half of the time you break your own bone.
Right. Okay.
So initial investigations were ABG shows pH of 7.32, bicarb 18, and lactate 4.2. Hemoglobin was 17.5, hematocrit was 52, creatinine 1.4, and CPK levels 200, and electrolytes sodium 135 and potassium 5.2. Heart rate was 115 beats per minute and sinus tachycardia on ECG.
Right. So how do you resuscitate these guys? So
coming to airway management, due to the presence of facial burns and hoarseness of voice, we proceeded with a early prophylactic endotracheal intubation to prevent anticipated airway edema and causing sudden obstruction. So patient was initially administered with 100% oxygen, and a difficult airway cart was kept ready. Using rapid sequence intubation, airway was secured with ET tube number 8. Post intubation, tube position was confirmed clinically, radiologically, and patient was placed on lung protective ventilator settings.
under what circumstances you would continue to give him 100% oxygenation?
Sir,
Under what circumstances? He may not have that, or may not have that, but
in during if any inhalational thermal burns and in closed space burn injuries, there can be a carbon monoxide intoxication can be there, sir. In those patients, we should give 100% oxygen. In those conditions, we
agreed.
can give 100% oxygen.
Continue.
Yes. So I have only one question. Like in your ABG, does your you have a facility to monitor the carboxyhemoglobin level?
Mm.
In your
Must be there. Yeah, must
Yes,
be
sir.
there.
Yes, sir.
Yeah, must be.
Okay, okay.
As it was negligible, we didn't mention it here, sir.
It was normal, sir.
Normal, okay.
Yes.
So his hemoglobin is so high, huh? 17.2.
Always do the serial things. When things are deceptively normal, always follow those things up, because eventually they may develop into what you had. Like lactate may shoot up to 10, and then the CPK, which is 200, will go in some thousands. Potassium
Yes,
level
sir.
will be all over the place.
We have mentioned in the later slides, sir.
Okay.
Yeah, okay, go ahead. Yeah.
So fluid resuscitation was initiated with Parkland formula, which was calculated as 4 ml per kg body weight into percentage of the burns. Here the patient is a 70 kg patient with 31.5% burns, and total fluid calculation for 24 hours, it came as 8,820 ml, and half of the volume is administered within the first 8 hours, and the remaining half in next 16 hours.
Again, is it the Parkland formula is appropriate for a patient of electrical injury? Do you really follow Parkland formula?
No, sir. In electrical injuries, we should do fluid resuscitation according to by targeting the urine output, sir. Urine output by
Okay.
keeping 1.5 to 2 ml to avoid that muscle injury and rhabdomyolysis and AKI. So in those patients, we will target a urine output of 1.5 to 2 ml per kg body per hour, and yes, sir.
What is the
This part,
flip side of over resuscitating a patient in thermal injury? What are the problems you can anticipate in thermal injury, particularly? You are given lots of fluids.
during resuscitation, sir.
Yeah, during or after resuscitation, you see that his CPK is going up and up and up and up, despite you giving fluids. Your limbs are becoming white. your potassium is going up, and you are giving, and you think that the fluids are inadequate. What is happening there?
Extravasation of the fluid can occur, sir, in thermal injuries.
Correct, and that will lead to
compartment syndrome,
What is that called?
fluid creep.
fluid creep.
Okay.
You said something na just now. Mumble something.
Compartment.
Compartment syndrome.
Correct. So you have to be very careful when you are resuscitating these people, especially when you have already mentioned there have been dual injury with the chest burns and all those things.
Yes, sir.
You should be very careful.
Yes, sir.
Again,
This
yeah, you can continue actually. I'll ask later. Yeah. So again, this patient came to you at what time, and this you have started the resuscitation. How much like the
After 1 hour of the accident, he has come to our ER, sir. Then we have started our resuscitation. After securing 18 gauge cannula in the ER itself, they initiated the resuscitation. Then we went and placed center line, and we have continued the fluid resuscitation, sir.
So your time of your resuscitation you have calculated from exactly which time?
From the burn accident time, we have calculated.
Right,
sir.
right. So it is the burn time, not the time the patient reaches the hospital. Okay.
Yes, sir.
So ringalactate was used as a primary resuscitation fluid. Fluid administration was not based on the formula calculation, exactly not on the formula calculation, but we are titrated according to the clinical response and urine output. Given the electrical component of injury and risk of rhabdomyolysis, we have maintained the higher urine output target of 1 to 1.5 ml per kg per hour. So strictly hourly urine output monitoring was performed by looking at a Foley's catheter.
So this patient was intubated. He was having a Foley's catheter. He was having a central line, right? Am I right?
Yes, sir. Yes, sir.
And he is also like okay, fine. So he's on ventilator with lung protective ventilation strategy. Okay, and this is the day one.
Yes, sir.
Yes, sir.
This is the day one, right?
Yes.
Continuous cardiac monitoring was maintained for 48 hours due to the risk of arrhythmias following high voltage electric current injury, and serial ECGs were performed.
So I just have one question. Sorry to interrupt. I just have one question. So did you consider doing a bronchoscopy because your patient has a upper airway injury? You was told that he has a like soot in the upper airway. There is a hoarseness. Do you consider, or is there any evidence, or what does bronchoscopy tells us in such cases? Is it going to be helpful in prognostication?
According to evidence, bronchoscopy is we can do bronchoscopy, but it won't help much, sir, because early bronchoscopy it won't help much because in early bronchoscopy it looks like a normal picture only, but in the later after 24 hours there can be any edema and inflammation of the airways and collections in the airways. They can be there, sir. So early bronchoscopy has no role according to.
Okay, but whenever the facility is available, you must consider a bronchoscopy because the only thing is that it will give you a very prognostication model of the injury of the upper airway. There are, I think, certain scores which takes into account the bronchoscopy grading. If I'm not wrong, there are some AB, the abbreviated burn injury scale, or something which you can just for the medical legal purpose you can put on paper because there are 4 grades: grade 1, grade 2, grade 3, grade 4. Those are very important on paper because then you can ideally do a follow-up bronchoscopy and you can know when the patient is not getting extubated or he has extensive injury of the upper airway or the lower airway also. Then those cases it will help you the follow-up.
Okay. Aggressive fluid resuscitation was continued to prevent the myoglobin-induced acute kidney injury. We monitored urine color, CPK levels, and renal parameters serially. Both upper limbs were closely monitored for the signs of compartment syndrome, including increasing pain, swelling, and neurovascular compromise. A low threshold for hysterotomy was maintained throughout the early course. These are the investigations.
Again, just a small point here I want to mention. So escharotomy, particularly in the electrical burns, it is like most of the times it is the fasciotomy which helps. So there is a difference between the escharotomy and fasciotomy. So particularly the electrical burns, since it involves the deep fascia and the muscles and the deeper tissues. So sometimes escharotomy may not help. Okay, so what you really need is a deep fasciotomy and proper treating the compartment syndrome. And they may go into the delayed compartment syndrome also. So there is a chance that the compartment syndrome may happen after 5 to 7 days. That is why you have to keep a very close watch. And here there is a recommendation, or you can ideally monitor the compartmental pressure and from clinically also, and also from your biochemical parameters. Okay, so the fasciotomy is one of the sometimes the standard of care in such extensive electrical burns.
Okay. Yes. So day one, we continued with the Parkland guided fluid resuscitation. A total of 8.8 liters for 24 hours was calculated, and additional bolus of 500 ml for persistent hypotension was given, and the MAP was maintained above 65 without any vasopressors. Initially, the urine output was low, but later on, after when you start the resuscitation, urine output was improved, and the target urine output was maintained at 1 to 1.5 ml per kg per hour. Patient is on mechanical ventilation with FiO2 to 40% and P5. In the ABG, shows a mild metabolic acidosis, which gradually improved, and continuous cardiac monitoring was done. No arrhythmias were detected. Electrolytes were corrected. And enteral nutrition was initiated within the first 12 hours.
Sorry, you have shown the tables, no investigations. So
yes.
Can you just go back to that? So what do you infer from this table? Like,
Sir, here initial on day one during presentation, urine output was little less, and CPK levels initially it was low, sir, 200, and on day two it went up to 15,000, sir.
And even hemo concentration was there, sir, on arrival. Later on, that has been subsided, and even lactates, which were on a higher end, 4.2 on the day one, has been improved to 1.2 to 1.3 later on, and creat has settled down, sir, and potassium he was on a higher end of normal range, that is 5.2, and later on it's been corrected. Urine output, which was initially a little lower side, has been corrected after fluid resuscitation. CPK levels were normal on admission. At the time of admission, has raised to 15,000 on day two, and followed declining trend after targeted urine output therapy.
have you given soda bicarb? Have you given soda bicarb to alkalize the urine? What is for this patient particularly?
No, sir. We didn't give soda bicarb, sir. Only hydration. With hydration only we.
Okay.
Maintain,
Okay. So particularly in this case, so your urine output which is a better predictor of your resuscitation here? Your lactate level or your CPK level?
In this case, the urine output is the predictor, sir.
So, but normally in a case of severe electrical injury, which is the better predictor, sometimes your urine output may be maintained, but you find your lactate and your CPK level to be persistently on the higher side. So how do you target your endpoint? See, Parkland formula may be initial starting point for your resuscitation, but endpoint is something different. So in particular these cases, sometimes even if the urine output may be maintained, Okay, but your lactate and your CPK levels sometimes gives you a better predictors of your resuscitation compared to your urine output. And one more thing, have you checked all the so you are happy with the resuscitation, right, for this patient? You didn't feel that his echo assessment, or see, what I want to stress here is that have you done any cardiac marker, because this patient are very high risk for going into myocardial ischemia, myocardial arrhythmias. Your 2D echo, what is the finding of the 2D echo, your troponins and other thing, have you checked in any of your day 2, day 3 or subsequently, or echo is been?
Echo was done on admission itself, sir. In the ER itself, we have done echo. Echo was showing normal myocardium with good LV ejection fraction. And cardiac biomarkers, we didn't send because we didn't find any ECG changes as such. So we didn't take that call of sending the cardiac biomarkers, sir.
And anything from your side, Dr.
I think that's fair enough. If as long as the ECG was followed up and should be okay. Technically, you should be doing it as a baseline. I would do it, but it's okay if there is nothing much.
On day two, blood pressure was stabilized. BP was 110/70. Heart rate was improved to 96 per minute. No vasopressor requirement. Urine output is adequate, and dark colored urine was observed. It is suggestive of myoglobinuria, and CPK levels were elevated to 15,000. Creatinine was normal. And on limb assessment, increased thickness in the right upper limb was observed, and capillary refill was slightly delayed. So bedside hysterectomy was performed for circumferential full thickness burn on the right upper limb with under the procedural sedation. Immediate improvement of the distal perfusion was observed. And ventilation sedation was continued with fentanyl. FiO2 was reduced to 35. On chest X-ray, there are no ARDS changes.
All right. So you have rightly diagnosed your limb to be going into compartment syndrome. Hmm?
Yes, sir.
It's very important.
Yes, sir.
This is most of the time being missed. Huh? I'll tell you. So, like proper eye and monitoring on the compartmental pressure as well as the clinical signs are very, very important here, actually.
Yeah, that was a good call, I would say.
Yes, yes.
Yes, sir. On day 3, patient was hemodynamically stable, afebrile, and no arrhythmias. CPK was in a decreasing trend. Creatinine was normal. On mechanical ventilation, SpO2 more than 96%. Enteral feeds increased to full target calories, and high protein and high calorie feeding regimen was prescribed to meet the hypermetabolic demands associated with the burn injuries. And wound care was done with the formal wound reassessment under the aseptic precautions, and deep burns were demarcating clearly, and the surgical debridement planning was initiated.
Okay.
Next slide.
On day 4, we did a cufflink test, which was a positive, and extubation was planned, and passive and active limb physiotherapy was initiated. Limb elevation was maintained. Edema was improving. No
Do you do
fever.
Koplik test for everyone?
No, sir. In this patient, we suspect any airway edema. We suspect, sir. That's why we are doing. We have done the test, sir.
Okay.
And no fever. WBC counts were in the normal range. Blood cultures were negative. No evidence of burn wound infection. And patient underwent first staged wound debridement under general anesthesia in OT. necrotic tissue removed, and temporary biological dressing was applied.
What antibiotic you have given to your patient?
Sir, in this patient, we didn't give any antibiotics, sir, as there is no evidence of any sepsis or sepsis. Prophylactic antibiotics have no role in the burns patient, so we didn't give any antibiotics. As per we have consulted with infectious diseases specialist of my hospital. He advised
I
not to.
really happy with the idea you have actually. So most of the times in this patient, if they come now, sometimes either ceftriaxone or piperacillin or many of the antibiotics has been started itself by the physicians, by the So this is very, very important. So like prophylactic antibiotic, unless until you suspect or unless until you prove there is an infection, actually sometimes like harms the patient.
Yeah, I would say that was an impressive step.
On day 5, patient was extubated, hemodynamically stable, adequate oral intake started, and the pain was controlled, converted from IV fentanyl to fentanyl patch, and urine output was maintained. CPK was normal, renal parameters were stable. 48 hours cardiac monitoring was completed, no arrhythmias throughout the stay, and wound was clean. Wound status was a clean wound.
List out, just for the pain, list out the escalating manner you would involve and list out the drugs which you will be using it in a stage-wise manner if the pain is not getting controlled. List out like first this, if not then this, then this, then this. You can say it gets added or replaced.
Sir, as this pain is due to burns, so there will be a little role of paracetamol and so we'll start with opioids only. Opioids, with opiates, if pain was not controlled, we'll go for ketamine infusion, and
benzodiazepines will be added along with it, sir. And as it is of more of neuropathic pain, nerve ending fibers are being affected. The patient complains of immense pain, which cannot be treated with normal normal PCM, and NSAIDs cannot be used because it may again become an add-on factor to the AKI. So we would go with opioid. Along with the opioid, multimodal analgesia, like either adding ketamine and adding benzodiazepines and even gabapentin, we would add for such cases.
Have you used inhalational?
Inhalational we have used for when the patient has gone, the patient went to OT for dressing, sir. There we have used inhalational. Ketamine was used on the day for extraordinary.
What do you use?
Sir, inhalational you meant?
Yeah.
Inhalational sevoflurane was used, sir, along with nitric oxide and oxygen as an inhalational part, and it was top up. It was all given along with fentanyl and ketamine, sir.
Okay.
Agree. Next slide.
So I just have one question regarding the nutrition. So what are the evidence-based micronutrient, or what are the evidence-based supplements, or what are your target? How do you measure the caloric requirement in such patients? What is the ideal methods? Like there are a lot of formulas are there. So how do you, because the caloric goal, to meet the caloric goal in such kind of patients are very, very important, because they are most of the times in a hypercatabolic storm. So they say that this hypercatabolic state, hypercatabolic state persists sometimes for the months also. Okay. And that is where your nutrition plays a very important role. So how do you plan the nutrition for your patient? For him, what is your ideal nutrition?
We would like to start. We have started his nutrition within 12 hours of admission itself, sir, so that to avoid the translocation of gut bacteria and even to avoid ileus. And later on day 3, we have escalated his nutrition with a high calorie and high protein diet with polymeric formula, so that because now the patient has gone into the second phase, that is a catabolic phase. So in this phase, the patient needs 25 25 to 30 kilocalories per kg, along with percentage of burns that has been involved into 40. So, and in this macronutrient portion would be protein should be 2 grams per
This
kg.
is called which formula?
Curie formulas.
But is the Curie formula is again a idealistic for ideal formula for the burn patient?
It is widely used, sir. At the same time, it has its loopholes. Like if the patient is unable to tolerate the feeds, then
Right.
that becomes a limitation. In such cases, partial parental nutrition can also be started in such cases.
So what is
Along
the
with
ideal method? I can estimate the caloric requirement.
indirect calorimetry is ideal method, sir.
You have indirect calorimetry. You have like any experience of indirect calorimetry for ventilated patients?
For ventilated patients, we would record the CO2, ETCO2, and then we would keep in some software would be there, wherein we would get direct values. I mean, how much is required.
Anyway, so you have like whatever you told is right. So mostly sometimes you're like the caloric and protein goals are like you depends on your need, and the need sometimes is more compared to the general patient population. So that is the reason. And what are the different other like for your supplements or your micronutrients which has shown beneficial, particularly in the burn patient?
In micronutrients, we have omega-3 fatty acids, then glutamine, vitamin C, then zinc and arginine. These are the selenium. These are the micronutrients which have their role in burns patients. For example, in vitamin C, it would avoid fluid creep. At the same time, it has a limitation that on excess dose or higher dose, if we give, it may cause calcium oxalate crystals in the kidney, again precipitating the AKI. And next, coming to the glutamine, there are studies showing that it is both beneficial as well as not much benefit according to few trials. And then next is
So what I can say, the majority of the trials which actually the published, basically they fail to show any significant benefit of such micronutrients particularly. So the standardized feeding is always better. Okay, if you can add, but there should not be any harm. That is what the main like I think context is. So how much protein you can plan for your patient at present?
2 grams per kg per body weight.
Okay, fine.
On day 6 and day 7, we monitored for any other complications and planned for split thickness skin grafting in the ward phase, and later on transferred to the burns ward for ongoing wound care and rehabilitation.
What are the long-term consequences you are expecting in electrical burn patient? System-wise, you can.
One is post-traumatic stress disorder. He will be having, sir. There are chances of PTSD, and
there could be SIRS for a long time. Sir, systemic inflammatory response would be there for a longer time, and then even contractures would be present. Higher risks of contractures could be present in such cases, and at the same time, disability if not addressed at the right time, or even addressed at right time also, especially when the upper limb is involved, wherein the fine movements are there, disability would be there to the patient. Then infections, secondary infections are a major stake for long-term complications that may impact recovery of the patients.
Yep. Particularly in the electrical injury patients, these patients are prone to have long-term seizures. They may present with the seizures later, and they, as you rightly said, contractures and all those things. Because of the blood vessels are also affected, they have accelerated atherosclerosis. So they will have later strokes or MI. And rarely, few patients, when reports have been there, of development of Parkinson's. So those are the few things which, on a very, very long-term basis. So whenever this, how to answer this question is will be the immediate effect, intermediate effect, and the long-term. Immediate, what you said just now. Intermediate, again, what you elaborated, post-traumatic, contracture. Long-term, more contracture, disability, Parkinson's, increase atherosclerosis.
And one more thing, I have not seen the DVT prophylaxis regimen for this patient actually. So have you considered?
That is one of the very important things.
So we didn't get.
Didn't get you, sir.
The
DVT
DVT prophylaxis.
prophylaxis.
Did
DVT
you?
prophylaxis.
DVT classes. Oh, we didn't mention it, but we have given from day one itself. We have started DVT prophylaxis. Day two, sir, because after osteotomy, we have initiated the DVT prophylaxis.
Why these patients are high risk for DVT? Particularly the electrical injuries?
I think they got disconnected.
Okay.
Yeah.
Yeah. Maybe.
Right.
Maybe.
But overall, I think they are well presented.
Yeah.
Case.
I would say that.
I think maybe they're rejoining, I suppose. Just
We'll wait for
Rejoining? Are
yeah,
they? Okay.
We'll wait for some time.
Ravi. Ravi, you can rejoin.
Are they joining or?
Yeah, they are rejoining, sir. Just
Okay.
a few minutes. Some technical glitch there. They are rejoining.
I think we were already at the end of the session, I guess. If they're not able to join, that should be all right. I mean, it was just a question of summarizing.
Yeah, that is okay. I think they are trying to rejoin just to till that time they rejoin. Just will summarize for the sake of the audience, sir. If anything, sir, you can also add because they have presented a very well case. Because usually we get either flame burn or we'll get electrical burn combined with electrical as well as flame burn is quite not very common, we'll say. So, and especially as the electrical one, as sir has already pointed out, what is the apparent injury may not be so severe, but deep down that might be having significant injuries. So, especially rhabdomyolysis, compartment syndrome, and before that, patient might be having rhythm abnormality outside hospital CPR also we have to see. And basically, AC current is more prone to cause ventricular fibrillation and arrhythmias. The next thing I think tetanus toxoid immunization is quite important whenever we go ahead and all when we take history of the patient. Probably one of the point that is important or probably missed is TT, tetanus toxoid, and the closed space burn or it is open space burn where the airway is involved, where definitive airway or maybe early airway intervention may be needed or not. And the next point is like coming back to the injuries. So electrical burn, they have extensive injuries, especially involving muscle, especially involving nerves also, and especially excruciating pain because of fracture, because of joint pain, joint dislocation. This patient might be during mobility also they have significant pain. So next thing is that resuscitation, well said. Only thing point I want to add is where the role of albumin comes, because when we see Parkland and all, they basically 4 ml per kg body weight from the time of injury, they say. So sometimes there may be fluid creep. So and there may be ongoing compartment syndrome also. We have to have cautious fluid because we have to have strike a balance. We have to involve the other mortalities also apart from urine output. What is the lactate trend? What is the focus finding it all that I think we have to incorporate. Next thing, what we antibiotics again. Antibiotics is initial period where there is a hyperinflammatory phenomenon. There is may not be initial stages, no need of any antibiotic. But you joined or Ravi?
Yes, sir.
Sorry, sir, for the interruption.
Yeah,
Okay.
I think you can continue. We'll see. This we can just summarize. Then we'll if any questions.
Yeah. So the only thing this is hyperinflammatory where will our traditional teaching like early organ dysfunction to start antibiotic may not be whole good, or we say commonly procal in our routine cases. This also or the inflammatory markers may not be very reasonable in this subset of patient, but we have to look for any new organ dysfunction or any other which is trend is like lactates are settling, but again lactates are started worsening, or again urine output is dipping. So any other under resuscitation or any other organ dysfunction, that also we have to see. And as well as nutritional, what you have said, excellent, but protein we have to target because these are hypercatabolic. So to begin with, they usually require in the range of 2 gram per kg body weight protein, and calorie requirement also we have to met. And as a like micronutrient, there is not much of role, but protein and calorie we have to meet as going this. Any other thing, sir, you want to add?
I think you have covered almost all the points.
Yeah, you have covered almost all the point. And the DVT prophylaxis.
DVD prophylaxis, correct.
Yeah.
Sometimes when you are trying to extubate these patients, one of the non-patient factors or the convenient factor is whether the patient requires frequent OT for the dressing. So if the patient is requiring 2 or 3 sessions, then even though he is meeting extubation criteria, sometimes you can hold on to the extubation. Because putting the tube in and out, because that becomes one of the criteria for keeping the patient tubed or
Yes,
not
sir.
to extubate the patient. So that is the thing. Coming to your albumin thing, it's always a double-edged sword, Sergey, because this being an extensive capillary leak, the albumin is going to seep out, and the albumin which will go in the third space is going to create a lot of trouble in de-resuscitation later. So that becomes another factor. But yeah, it's if you are pushed to the wall and we are looking at resuscitation, you can use the albumin. And that's one of the reasons they have not promoted albumin in burns. That later consequences, ARDS, leak consequences, because this is a pure inflammatory state. So that's going to have major consequences across.
Yeah, definitely, sir. Because even albumin first is a crystalloid based resuscitation. So I think we have too much of crystalloid, then probably after initial resuscitation, probably role of albumin may.
Yeah, that could be there.
Yeah.
So well presented, Ravi.
Yes, sir.
Sorry. And yeah, I don't have anything to add. It was well presented.
No, I think well presented, and I think a good discussion also.
Yeah.
And so I must congratulate both of them. So it's a very nice presentation.
Yeah, sir. Thank you, sir, both of you, Gunadhar sir and Anand sir, taking out your precious time and guiding us and student and those who are audience also. So it is a good good take home case. So a lot of point we are re-emphasized, and it is really good discussion. Thank you. Thank you, Dr. Ravi.
Thank you.
Thank you.
So, okay, thank you.